this systematic review was kind of split two ways. And one of them was looking at the prevalence of BRAFV600E mutations. And so basically, because the paper was split, I did one half, and my co-author, Lily Andrews, she kind of did the other half. So I can't say a massive amount about that half because I don't have all that information in my head. But from what I do know, we found that there was a few ones where a few different types of entities where the prevalence of BRAFV600 mutations was a lot higher than the 1-2% that you'd expect. I can't remember off the top of my head what they were, but what I do remember is that there was a couple of patients, and it was a very small data set. There's an entity of glioma which it just gets called PLNTY, and it stands for I can't remember exactly what it stands for, but the NTY at the end stands for neuroepithelial tumor of the young. Basically, it's a tumor which I don't think clinicians see it very often. It's quite rare. It's a pediatric type of tumor. And we only had 6 patients, I think. So obviously with prevalence, the more people you have, the better it is. You get a better picture. So I'm sure, I think Lily said she was going to be speaking to you as well. So Lily will tell you about that part. But yeah, so the inhibitor part I can talk about because that was kind of my bread and butter in the paper. So yeah, basically we looked for patients who had brain tumors, who had glioma, who were treated with a BRAFV600E inhibitor, and these, we didn't within the set strategy for the systematic review, we didn't put a restriction on which drugs, but the two that kind of cropped up the most are a drug called Vemurafenib and another drug called Dabrafenib. And basically the way they work is they block the protein from working, which causes the cancer cells to proliferate and grow and divide. So we didn't kind of put any restrictions on patients they could also be treated with kind of chemotherapy, surgery, radiotherapy. And what we found as well as we were going along, a lot of these patients who were treated with BRAF inhibitors were also treated with MEK inhibitors. So the way BRAF or BRAF, whatever you want to call it, the way it works is it's a downstream regulator of normally of things like EGFR. They kind of seem to be surface membrane receptors, and then they get activated by a ligand, and then BRAF would be activated, and then BRAF goes on to activate MEK. And this is part of the MAPK pathway. So what we found within the literature itself was a lot of patients were taking BRAF inhibitors, and they'd start off really well, and they'd respond really well to the drug. Very little kind of adverse events. Sometimes people would, I think the common ones seem to be kind of rashes and things like that, but they would be treated with like topical steroids. And then kind of after 12 months, maybe 9 to 12 months, these patients then started to kind of deteriorate again. And I think when we looked at, because we didn't put a restriction on kind of how far back we looked, I think when these drugs first started to be used, I think the clinicians started to pick up on this and trying to think, okay, what can we do now so that these drugs, people are having maybe a year free of any kind of symptoms, but then the tumor goes on to progress. So I think as we kind of looked at the more recent papers, clinicians started to notice this, and the patients would go on to be given dual therapy with MEK inhibitors. There's a lot more of these. I can't remember. I think Trametinib was one. I can't remember, but there's a few of them anyway. And yeah, what you tended to find is that patients who were given the dual therapy responded a lot better to people with the single therapy, and that kind of went for patients with high and low grade tumors for glioma. So tumors at the time, so now the WHO 2021 CMS classification of tumors has come out, which it got published not long after the paper got published. And we were using the 2016 classifications, and it was a lot more kind of laid out there. Everything kind of had its own grade, whereas now things have changed a little bit, and kind of like astrocytomas now could be grade 2, 3, or 4, where when we wrote the paper, they were either grade 2 or they were grade 3 when they were anaplastic. But anaplastic has been dropped now. It's no longer a term that we use. And we basically found that these patients who had dual therapy tended to have a better progression-free survival and overall survival when they were given the dual therapy. This is the same for low-grade patients, high-grade patients, pediatric patients, and adult patients. They all seem to benefit from the drug. And I mean, with glioblastoma, the overall survival is not great anyway. It's got a really bleak kind of expected survival time. I think something like the 5-year survival time for glioblastoma is really, really poor. And even for 12 months, it is quite low. So these patients did seem to benefit. But again, it's small sample sizes but that's just the nature of glioma. The small sample sizes didn't help. But we did find some, positive stuff. And I think now that I know recently that the NHS have now given the go-ahead for people with brain tumors to have their sample, like biopsies, basically sequenced to look for mutations. I think previously, I could be wrong here, but I'm pretty sure it wasn't paid for on the NHS. And I think the whole rationale of this paper was we saw how well that these drugs fared in people with melanoma. That's where the drug is really good at, these V600 mutation inhibitors, because melanoma, its mutation crops up a lot. And patients with these melanomas, they do amazingly well with these inhibitors. So I think the whole point of the paper was kind of say, look, there is a drug out there. It's already out there. It's already been approved. And these mutations do crop up in brain tumors. So kind of, why aren't we using them when we can use them? When the mutation is there, it's going to be so much better, beneficial for patients who have that mutation. And I guess that's kind of why we did the paper as one with Lily's part and said, okay, it is a beneficial drug, but how often does this mutation crop up? Is it going to be worth saying, looking at this drug and saying, is it worth using? And don't get me wrong, in some, the prevalence is very, very small in some types of tumors. But in others, it was quite high. It was considerably high. And I think this paper was published back in October now, so it's actually been quite a while. And we found my supervisor, Professor Catherine Akurian. She's a professor at the University of Bristol, and she works at Southmead Hospital in Bristol. And she was saying that there has kind of been an increase in people talking about BRAF and the potential of using BRAF as a therapy, BRAF inhibitors as a therapy, I should say. And we seen not long ago, only a couple of weeks ago, that there was a patient who I think it was a pediatric with a high grade tumor, which is actually quite rare. You tend to find pediatrics have low grade tumors, and then as you get older, it develops into a more high grade tumor. I believe that this patient started on a BRAF inhibitor, and I think that up to now, within the time the paper was published, I think the patient was faring quite well. They'd had alleviation of their symptoms. So I guess with the idea obviously is to make for any biologist, the thing is, let's get rid of cancer, let's cure cancer. And I think with anything to do with glioma, especially glioblastoma, it's all about giving the patient as long as you can give them, and trying to give them the life where they're not suffering, or it just basically it's all about quality of life. And I think that when we looked at, you know, people who typically have kind of radiotherapy and chemotherapy, it's associated with all these horrible side effects. And I think with the patients where BRAF inhibitors do work, I think it's a great thing, because we've noticed that the patients are just, they took it up so well, and the quality of life was just so much better. So yeah, I guess now that, like I said, the genetic testing is available on the NHS, you know, it's a good idea to, you know, search for this mutation. If it crops up, if it's there, say, okay, there's a drug already there, let's use it, let's see what happens. And don't get me wrong, the patients that we looked at in the systematic review, I don't think there was any where they hadn't had surgery or chemo or radio. So I think these other things still need to take place, because obviously we know that is the best chance we have of reducing cancer and getting rid of cancer and shrinking the cancer. But I think if that drug's already there and available and it's proved to work on other cancers, let's use it. It's shown to work, and I think it's one of those drugs that a lot of people don't know about, and I think it should be known.